All right, so welcome everybody to this session. Very excited to have you all and very excited to see our speakers as well. So I just wanted to go over quickly some housekeeping items. So we have 15 minutes for each presentation, about 10 minutes for the talk, and then 5 minutes for Q&A. We request that the audience with questions, please walk up to the mic there to ask the question. We'll probably try to have 1 or 2 questions within the 5 minutes. And we'll also probably have or give a 1-minute reminder or a wave to the speakers when they are around 9 minutes, so we stay on time. So with that, I wanted to introduce our first speaker, Daniel Tai, who is a clinical pharmacist doing PhD in pharmacoepi in National Cheng Kung University in Taiwan. So all yours, Daniel.
Sorry. Okay. Thank you for the introduction, and lovely to meet all you guys here in ICP 2023. And I'm sure you're all like have a full meal, so just keep calm and listen to my relatively regular presentation. So this is Daniel. I am a clinical pharmacist by training, also a junior pharmacoepidemiologist in Cheng Kung University, Taiwan. And today my topic is about the augmentation therapy and suicide risk in patients with treatment-resistant depression. And we use a target trial emulation framework to study this question. So I've got no conflict of interest to declare. So let's see the background. So we all know that depression is kind of like a third disease burden across the whole world, and there's some projection study confirm that. And so treatment-resistant depression, you guys all like very familiar with depression, but treatment-resistant depression is kind of like a subset of depression, which is kind of like they are really like treatment failure and they're really hard to treat them. And they also have a really high mortality compared to a non-treatment resistant depression. So the clinical treatment is kind of like complicated. You have like different intervention for that, but especially some of the treatment strategy would be using third line of antidepressant, using like different classes, have different classes compared with their prior antidepressant, or they would use antipsychotic augmentation treatment to treat these kind of special patients. However, we all know that the effectiveness of this is kind of like unclear, and it's really hard to like do clinical trial in psychiatric diseases, especially we also have a really special target for these patients. So therefore, we'd like to develop a study and then to see that how's the effectiveness of antidepressant or antipsychotics in these treatment-resistant depression patients. So as you all hear a lot of the stories by Miguel Hernan, we have applied the target trial emulation framework, but kind of like not that complicated for that. We have because we've got an active comparator. So we kind of like using this framework to think about what kind of like target pragmatic trial would be used in this kind of scenario. So these are like 8 dimensions of the like common target trial emulation framework. So we use like they're nearly all the same. So compared to the target pragmatic trials, and our treatment strategy would be the augmentation therapy of antipsychotics or augmentation therapy using third-line antidepressant. And our primary outcome is suicide attempt and complete suicide. The reason for that is for antipsychotics, for depression studies, it's really hard to find an indicator. And most of the studies, they use suicide as a proxy to see how their effectiveness works. So we also like follow them, start from they initiate their therapy till they death or those follow up or the last date of the database. So we did two kind of causal contracts. One is intention to treat, another is per protocol effect. And the statistical analysis, we use the Cox regression model to generate the hazard ratio and confidence interval. So these are the target pragmatic trial we have, and then we literally did the same thing for the emulated trials, and I can have more details afterwards. So for the data sources in Taiwan, we've got a really good database. It's called National Health Insurance Database, which contains 23 million of the patients, and all the Taiwanese patients, they are all enrolled in this database. So we've got a population-based cohort studies, and we included patients with treatment-resistant depression between 2011 till 2020. So our study cohort would be like patients diagnosed with depression who had previously already received two antidepressants. But there's some issue because we don't really know that whether the antipsychotics is prescribed for the treatment the TRD patients. So we kind of exclude some common indication that would prescribe antipsychotics. That is dementia, schizophrenia, bipolar disorder, and alcohol and drug abuse. So we've got our eligible patients. So since we like identify our like predefined cohort, and then we see that who take the antipsychotics first or the third line antidepressant, and that is our time zero. And start from the time zero, we would keep follow them, and until they had their outcome occurred, which is the suicide attempt or complete suicide, and all-cause mortality and cardiovascular death. And our look-back period for baseline characteristics is about 1 year day. So for statistical analysis, surely we use propensity matching to match all the baseline characteristics, and we describe the continuous variables using mean and standard deviation, categorical variable using number and percentages. And then we use SMD to describe the difference between antipsychotic group and antidepressant group. Then we calculate the incidence rate for the number of mortality and number of suicide attempts in these defined cohort. And then we also use a incidence curve to see how the time trend goes. And as you all know that like suicide attempt is not it's like they attempt to do suicide, so they didn't actually dead. So there's a competing event with death. So we use both models, which is cause-specific hazard model and fine-grained models, to see that the competing event will affect our result or not. So these are our results for baseline characteristics. Our patient is about 55 years old, and most of them are female. And then I think I would like to say like most of the baseline characteristics was well matching after the propensity score matching. But we do see that the cumulative duration of the previous cumulative duration of antidepressant is different between antipsychotic group and antidepressant group, which will put them into the regression model to do the adjustment. We'll put it into a model to do adjustment. So let's see the results. So for the results, as you can see, like the blue line means the antidepressant group, and the orange line means the antipsychotics group. And the left one is the suicide attempt outcome, and the right one is complete suicide outcome. So you can see that in the suicide attempt, actually, antipsychotics can lower the incidence of suicide attempt. However, when we reach to the complete actual suicide, we didn't see much difference. And then the hazard will be at the next slide. And we also do some like well-known outcome to see whether there's still some safety issue in these kind of patients. So like sort of cardiovascular death or all-cause mortality. And it do confirm our like previous knowledge that in the cardiovascular death or all-cause mortality, they do increase the mortality and death rate. So as you can see, the hazard ratio for the suicide attempt, there is a reduction of 23% of suicide attempt in antipsychotics group. And then we also do the competing risk adjustment, and the hazard ratio didn't change a lot, and the result is consistent in between both groups. But when we focus on like the later point for the actual complete suicide, we didn't see statistical significance in hazard ratio. Then for the cardiovascular death and all-cause mortality, there's the increased risk of cardiovascular death and all-cause mortality for sure. But you can notice that the incidence rate is quite different in between these groups. So we reach our conclusion. This is a retrospective cohort study using target trial emulation to study the effectiveness of antipsychotics and antidepressant. Then compared to the third-line antidepressant, we do see the reduced risk of suicide attempt. However, we still got to consider the cardiovascular risk in these kind of patients before prescribing. I think that's all, and thank you for all the feedback from our lab.
The floor, please come to the come to the mic there. Thank you.
So just a quick question about the last point you made. So where you have a completed suicide as an outcome. So if a person is on their second or a third attempt, so they have do you censor them if they had a unsuccessful, I don't know the proper language to use, but unsuccessful attempt for suicide, and then subsequently they tried again and then they died?
Yeah.
So how would you adjust for that? And second, another part of the question is about the death as competing risk. So you said you ran a competing risk model with death as a competing risk, but successful suicide death is also an event, right? So how was the adjustment made?
Sorry, I think I didn't make it clear. So the competing event is only considering the suicide attempt outcome.
Oh,
so that's your second question. And for your first question, I think we actually exclude the patients had suicide attempts in the complete suicide outcome as a sensitivity analysis, and the results I didn't present it here, but the result didn't change a lot. Yeah.
All right.
Yeah.
Thank you.
Thank you for the presentation. It's really good. And it's actually related to my also dissertation research. So I have a question in terms of the duration of antidepressant use, because SSRI usually takes 4 to 6 weeks to work or to exert clinical response. And your definition for 2 subsequent antidepressant use is 28 days. So how did you actually consider more than 28 days of use of antidepressant use? I mean, the different length of the previous antidepressant use.
Yeah. So sorry, because there's only 10 minutes.
Okay.
But I think it's a fair question. It's really important. So for the exposure, we actually do like the prior to so we define the prior to antidepressant using 28 days. So if they only have 7 days, that won't be counted as a exposure. I think so. We are trying to avoid kind of like misclassification of the exposure, because sometimes in Taiwan, doctors would do some therapeutic try to kind of prescribe for 7 days, which we don't really consider them as the actual use of antipsychotics or antidepressant. Yeah.
Okay, thank you very much. Yes, my name is Sam Hawley. Thank you for the introduction. I'll start just by showing our disclosures, and I'll just mention this presentation reports on a larger body of work called the recurrent intra-articular corticosteroid injections in osteoarthritis, the Rubicon study, and that's funded by the NIHR. So the background to the study, intra-articular corticosteroid injection is recommended by NICE for the treatment of uncontrolled pain in people with osteoarthritis. That NICE guidance explicitly states that there is no evidence for therapeutic benefit beyond 3 months after the injection. Other literature identifies a need for more research, more data on the relative effectiveness of recurrent over and above a single injection. And it's not clear from the NICE guidance how frequently those injections should be occurring. So our aim here was to assess the longer term effects of single and recurrent intra-articular corticosteroid injections for knee osteoarthritis on subsequent use of pain medications, and then also knee replacement, both as strong proxies for pain. So the data used, we used a cohort of incident knee osteoarthritis patients from the CPRD from 2005 to 2019. We had various exclusion criteria. These are just some of them. So we excluded those patients who had already been referred to orthopedic surgery at the point of their diagnosis of osteoarthritis. Also excluded patients who had had a historical a history of using intra-articular corticosteroid injections, and also osteoarthritis patients with at the knee, but who also had a diagnosis of osteoarthritis at another joint due to the it was difficult to ascertain which joint had been injected in that instance. So we limited it to just those with only knee osteoarthritis. The exposure was an intra-articular corticosteroid injection into the knee versus no injection. And our primary outcomes were measured over 5 years of follow-up. Firstly, incident pain medication use, and that was paracetamol, NSAIDs, opioids, and oral corticosteroids measured, analyzed separately, and then knee replacement surgery. And secondary outcomes, we looked at the outcome of the knee replacement for those that had it, so post-operative complications and reoperations. Our main analysis used a instrumental variable approach due to the strong confounding by indication expected for the intra-articular corticosteroid. So our index date was 180 days after the osteoarthritis diagnosis. And the instrument was defined as general practitioner, the GP practice preference for injections in the year period, in the 1 year period before index date. That was defined as greater than the national median over the previous 20 patients seen at that GP practice for each patient. We estimated then preference for single and repeat injections separately, and then used a two-step Poisson regression model to estimate the treatment effect where the IV strongly predicted the injection, and where also the covariates were balanced across the IV levels, defined as standardized mean difference of no greater than 10%. And then we did various sensitivity analyses, adjusting for geographical region of the country and calendar year, using a slightly later index date, but still a 1-year look back. A complete case analysis, so only those with complete 5-year follow-up, and then also using linear regression rather than Poisson. As a secondary analysis, we used propensity score matching, new user cohort with the index date being osteoarthritis diagnosis date. We had over 60 covariates, demographics, comorbidities, and co-medications to estimate the propensity score. And then each patient who had an injection during follow-up were matched to 2 non-injected patients using greedy matching. And then a time-varying Cox regression model used, following patients up to the earliest of the outcome event, which would be the incidence of a pain medication or knee replacement, death, transfer out of the database, end of study, or 5 years follow-up. So moving on to results, for our main IV analysis, we had approximately 60,000 osteoarthritis patients. Approximately 2,500 of them had an injection in that 1-year exposure period. The IV was strongly predicted receiving an injection, so odds ratio 5.6, F statistic 233, and all the patient covariates were balanced across the levels of the IV. So apologies for the small text, but this is just to show comorbidities on the left there, co-medications in the middle, and demographic and lifestyle factors. So we've got age, sex, deprivation, BMI, drinking and smoking status, all well balanced between preference for injection. I should note that there was marked differences when comparing actual exposure of injection to users and non-users, but that disappeared here when we considered it at the level of the IV. Moving on to then the actual outcomes. So this is showing the percentage of these patients who go on to initiate a pain medication during follow-up. And as can be seen, there is something of a trend of increased initiation of pain medication amongst people who had the injection. However, when we look at that stratified instead by IV status, there's something of reversal. So the practices that prefer using injections actually had a lower incidence rate, it would seem, of subsequent pain medication initiation, in something of a dose response format there, between no preference for no injection, single injection, and then repeat injection. And then that carried on over into the 2-step Poisson model output. So this is the scaled risk ratios from those models, showing there was quite a strong and significant decrease in subsequent pain medication initiation associated with injection usage. I'm not showing the sensitivity analyses because of time, but they were all similar to the main results, and I'm happy to discuss that later. Interesting. Moving on to the propensity score findings. So in total, the total number were different for each outcome, but it ranged from 12,000, approximately 12,500 to 22,000. Excellent balance across covariates. And we found also a reduction using the propensity score in NSAIDs, oral NSAIDs. Also a reduction in partial opioids, at least for associated with single injection, and also a reduction in topical NSAIDs. However, a slight increase in opioid usage using the propensity score matching method. Coming to knee replacement, the IV results again predicted a strong decrease in need for knee replacement associated with injections, and the relative risk there of 0.52 equated to approximately a number needed to treat of 17 patients to prevent 1 knee replacement in that 5-year period. So quite a clinically meaningful decrease as well. We weren't able to look at repeat injections though, because they were different across, the covariates were different across levels of the IV. PS matching again performed well in terms of balance. Interestingly though, very different findings. So in the propensity score matching approach, injection was associated with quite a large increase in knee replacement during follow-up, single and repeat. Reassuringly, there wasn't any association with the outcome of the knee replacement amongst injection users. So this just shows post-operative complications and reoperations were approximately the same between those two cohorts. So it's a large generalizable cohort. The IV analysis we used as our main approach dealt with the strong confounding by indication and unmeasured confounding also. Limitations, we did not have a validated code list for the injections. So that's an unvalidated code list. We probably missed injections happening in secondary care hospital setting, which probably were ultrasound guided also. So there maybe would be some bias to the null there. Some prescriptions we've used obviously are sold over the counter, so some misclassification of the outcome, and the preference-based IV we used was in that 1 year period around osteoarthritis diagnosis. It didn't account for switching during follow-up. So to summarize, short-term pain reduction following an injection, which is already known, may translate to a longer-term reduction in need for analgesics amongst knee osteoarthritis patients. In main analyses, we found generally a larger reduction for those with repeat injections than single. Again, in the main analysis, they suggested possibly a reduction in knee replacement with no adverse impact on the outcome of that knee replacement. And propensity score models confirmed a reduction in pain medication initiation for some medications, however, a slight increase in joint replacement. So further research is needed. I'd like to thank the Rubicon study team and our PPI group, and would like to take any questions. Thank you.
Very interesting presentation. We'll take any questions.
It's Ben Bray, LCP in King's College London. Super interesting talk. The IVs are always really interesting, but throw up quite a lot of challenges, as you've illustrated. I'm just wondering, do you think that your instrument, your findings reflective of instrument may have actually directly predicted the preference or practice to prescribe pills versus injections and referral to surgery? So it wasn't looking at treatment effect, but just a wider
I see. Yeah.
treatment practice.
That's an excellent point.
Yeah.
Yeah, and that's we've not been able to disentangle, as you point out there. From our data, we have primary care routinely collected data. The patient themselves may have a strong preference either for surgery or injection. We've not been able to capture that. The clinician themselves may have underlying reasons for either injection or maybe end-of-life care, for example. You wouldn't be going down the surgery route for someone in palliative care. So there's these kind of more global preferences that we haven't really been able to capture. But it's reassuring that across the sort of 60 or so covariates, there was balance. But it's an excellent point, yeah.
We have time for one more question. Anybody? Okay, looks like not. Thank you very much for a very nice presentation. Our next speaker is Erwan Ruzek from Roche.
Good afternoon. Thanks for the introduction, and thanks for the opportunity to present this afternoon. So it's my pleasure to present this study, which explored the use of clinical trial data and real-world data to perform comparative effectiveness measures for disease-modifying therapies in multiple sclerosis. So here are the disclosures. The study was funded by Roche. So as a background, multiple sclerosis is a chronic immune-mediated disease of the central nervous system, leading to neurological symptoms and accumulating permanent disability. It affects more than 2 million people worldwide, and MS disease course is usually defined as either relapsing or progressive phenotypes. Ocrelizumab is a monoclonal antibody approved for the treatment of relapsing multiple sclerosis. The clinical efficacy was demonstrated in a pivotal phase 3 trial against interferon. There is no head-to-head trials comparing ocrelizumab versus other disease-modifying therapies in MS. There are comparative effectiveness studies using real-world data which have been performed for other several DMTs. However, for ocrelizumab, real-world data datasets with ocrelizumab remain limited in the real-world setting for treatment exposure, sample size, and duration of follow-up. So in this context, we have decided to explore clinical trial data combined with real-world data to compare the efficacy of ocrelizumab versus other disease-modifying therapies for relapsing MS. So we use two data sources. First, the data from the pivotal phase 3 trial for ocrelizumab, so-called OPERA, and the subsequent open-label extension phase. The second data source was the German Neurotrans Data Registry, a network of neurologists across Germany, which includes 25,000 patients with MS. From the clinical trial data, we included all patients randomized to ocrelizumab or interferon. However, we excluded the US patients. We applied this exclusion criteria because we wanted to get a more comparable cohort to the German NTD population, and also because we were anticipated issues in adjusting for baseline differences in body mass index between the US OPERA patients and the German NTD patients. From the registry, we included adult patients with relapsing MS, with neurological stability, who initiated one of the 6 disease-modifying therapies that we included in the study after 1st January 2009. In terms of methods, so we use the patient-level data of the two data sources to build a one-to-one prognostic score match cohorts using a greedy algorithm. The quality assessment of the prognostic score matching was based on comparison of summary statistics of the baseline covariates, pre and post matching, assessment of the standardized mean difference for confounders distribution, and density functions of the prognostic score distribution pre and post matching. The efficacy outcomes were the time to first relapse and time to 24-week disability progression over a period of 5.5 years of follow-up. We applied an intention to treat approach using all outcome data, irrespective of treatment switch. And we estimated the hazard ratios controlling for up to 7 baseline covariates. You can see here the covariates that we selected as matching factors based on empirical knowledge and published evidence. We use slightly different matching factors for the relapse outcome and for the disability progression outcome. For the relapse outcome, we planned a sensitivity analysis, excluding the brain imaging lesions as a matching factor. So before moving to the results, just to say that we shared and transferred the clinical trial data to the CRO, which work usually with the NTD registry. So the study dataset and all statistical analyses were done by the CRO. So in total, we included about 600 patients from the trial and 7,000 patients from the registry in this analysis. We then, after prognostic score matching, built 6 different per match cohorts for each disease-modifying therapy and each outcome. I'm not showing for, due to time constraint, the results of the quality assessment of the prognostic score matching, but overall, it resulted in well-balanced baseline covariates and matching factors. So we first started our study by looking at the validity of our point score matching approach and the exchangeability of the two datasets. So for this, we compared a match cohort of patients treated with interferon from OPERA and from the registry over the 2 years of the trial double-blind period. So after that, we noticed a numerical trend of fewer relapses and fewer disability events in patients treated with interferon in the OPERA match cohort. However, we did not see a significant difference when we compared this for each outcome. So we consider this as an acceptable exchangeability of the datasets. So based on these findings, we decided to move further and completed the full comparative effectiveness on the 12 comparative cohorts for each outcome. So in summary, we find that ocrelizumab was associated with a significant risk reduction in time to first relapse and disability versus any treatment pathway in the NTD, regardless of each indexed DMT. We noticed that one comparison was marginally significant. This is the one comparing ocrelizumab with natalizumab, which is labeled as NTZ here. In terms of the sensitivity analysis for the relapse outcome, we did not see different findings when we excluded the existence of brain lesions as a matching factor. You can see here all the Kaplan-Meier curves that we generated for this analysis. We also looked at the treatment pathway discontinuations in the NTD match cohort. So for all treatment discontinuations and treatment switches. And over the observation period of 5.5 years, we found that above 50% of the patients in nearly all the NTD match cohort discontinued their index therapy for each outcome. So in MS, the use of clinical trial data with real-world data remains largely unexplored. To our best of knowledge, there is only one study which explored this method. However, they did not use the intention to treat approach. So strength of our study is that we use patient-level data from the trial and from the registry, high-quality registry data, including good density of clinical visits, patient assessment, and with brain imaging data. We were able to do a feasibility assessment of our propensity score matching comparative approach. And the ITT framework helped to account for the dynamic of the treatment pathways that we observed in the NTD match cohort and to mitigate the informative censoring. For the limitation and challenges, they were mostly related to the data privacy, the use of secondary data or secondary use of data, as well as the operationalization of the sharing and the transfer of the data to the registry or to the CRO. Main limitation is also that the propensity score matching resulted in small sample size of the cohorts, especially when we included the brain imaging data. So it limits the generalizability of our results. So in summary and in conclusion, we believe that this approach of combining patient-level data from clinical trials and good real-world data quality with propensity score matching and intention to treat method allowed us to compare the efficacy of several disease-modifying therapies in controlling the risk of relapses and progression of disability in relapsing of MS. From our point of view, we think that this is particularly useful in the current absence of head-to-head trials comparing multiple DMTs. Potentially, it could be applied and generalized to other disease areas. For future research, we are currently exploring other methods accounting for time-dependent confounders to further assess the effect of the disease-modifying therapies conditional on treatment persistence. So thank you, and I'm happy to answer your questions.
Question, please.
Quick question. It's been my experience that often wonderful scientific innovations get stopped by operational challenges. So one of my questions is, how long after completion of the phase 3 and the open label extension did you do this analysis with the data? And the second one is, Did you attempt to address, or were you concerned at all about the possibility that some of the patients in the registry may also have been in the trial?
So for the first question, the open label extension phase is still ongoing.
Hmm.
So the challenges that we had is that the initial patient consent for the clinical trial did not include the additional analysis and sharing to third party. Fortunately, it was done when after 3 years of the extension phase. So that's why we had to cut off at 5.5, but we could potentially do it again, that the study is now up to 9 years of extension phase. So that's, but it was this issue. And the second question was, sorry.
Whether you considered the possibility that some of the patients in the trial were also patients in the registry?
No, so the number of patients in Germany was very limited, very limited. So overall for the population, I think it was 700. But yeah, so in short, the risk of, but officially we did not check that it could be, so maybe 1 or 2 patients could have been,
Not a
but
big
it's
deal.
the number of centers from Germany, including the trial, was limited, and so therefore it should not
Thank
have
you.
existed.
Any questions? Yes, please.
Yes, thank you. Very nice presentation. I was wondering, maybe I missed this, but I was wondering how the hazard ratios compared for the trial, for the bleeding comparison. So the treatment versus the interferons and the observational study. And did you ever consider using the observation, that comparison as just a control outcome, and then try to address the unmeasured confounders using that as just a control by using the differences between the trial and the observational studies in that comparison?
No, we did not. What we really want is to make sure that the comparison of the interferon patients in the NTD could be compared to the OPERA trial. Not necessary for the unmeasured confounders, because our reference is a clinical trial itself. It's not the real world data who is the reference of comparison. Hope that's answer your questions.
Quick clarification. So the hazard ratio that you show for the comparison in the observational study was 0.30. I was wondering how that compared with the trial results, and if there are big differences there, you could use this as a control outcome.
So yes, so compared to what was found from the clinical trial, it's relatively similar. So the treatment effects not the same, but it's relatively similar. So that's also, yeah, comparing to the trial where we considered it was okay.
Patrick Blaine from Bordeaux. Thank you for this nice presentation. I'm not sure to well understood how you select a patient. It is a new cohort user design, or patient could be treated by 1 or 2 or 3 treatment before, on if this is the case, how you take this account in your analysis?
So each patient, so we take the first treatment initiated, but so we considered each time the cohort as a separated cohort. So if the patient started interferon, interferon as the first time, we follow this patient, or we included this patient from the first index therapy, and independent of what happened to other treatment switch. If this patient then started, I don't know, at some point in time, natalizumab at some point, when we did the comparison, we took all patients who started natalizumab for the first time, and we considered this as a separate cohort. That's how we did this comparison.
Thank you very much. So the next speaker, we have Dr. Shelley Wen from Harvard Medical School.
Hi, so I'm here to present on behalf of Will Feldman. Will Feldman carried out this work. He's a pulmonologist, practicing pulmonologist, also does work in policy and ethics, as well as pharmacoepidemiology. And so the work that is being presented today is from a paper that was just recently published in the Annals of Internal Medicine. It's about the comparative effectiveness of generic versus brand name fluticasone, salmeterol, the dry powder inhalers used to treat COPD. So here are his disclosures. It was a sudden switcheroo, so I apologize in advance because I just saw these slides a couple of hours ago. So he has previously consulted for Alosa, a nonprofit organization, as well as Etion, a software company. He's also been an expert witness in litigation against inhaler manufacturers, and this work was published or was funded by the NHLBI. So inhaled drugs are drugs that act locally in the lungs rather than systemically, like an oral or intravenous drug would act. And so when the FDA is evaluating bioequivalence with inhalers, they can't use the standard pharmacokinetic studies that they would for other types of drugs. And what they instead use is a weight of evidence approach that includes both in vivo, in vitro, and human factor studies. So the first generic maintenance inhaler that got approval, there was a whole bunch of brand name drugs that were recently approved by the FDA. The first generic one was Wixela Inhub, which is a generic version of Advair Discus. And so Wixela, the generic version, was approved in 2019, and it was approved on the basis of a clinical trial that was performed in asthma patients. Although the trial was performed in asthma patients, the generic was approved for both asthma and COPD patients. And another thing is that this trial was only examining a surrogate endpoint of forced expiratory volume rather than the clinically relevant endpoint of exacerbations. So because of these issues with the bioequivalence studies that you can't do for inhaled products, and the fact that this drug hasn't been evaluated, the generic version has not been evaluated in the COPD population. This study is about using real-world evidence to compare effectiveness and safety of the generic version versus the brand name version of fluticasone salmeterol in COPD patients. So the database that was used was Optum Clinformatics. This is a US commercial insurance claims database, and the inclusion criteria were pretty simple. It was basically new initiators of either Wixela, the generic version, or Advair, the brand name version, who initiated between January of 2018 and June of 2021. And they were required to be naive to prior use of all inhaled corticosteroid LABA combinations because Wixela and Advair are an inhaled corticosteroid long-acting beta agonist combination. So it was to the entire class there, dual class. All of these patients also were required to have a diagnosis of COPD within the 180 days prior and at least 100 days of continuous enrollment in this insurance database. They were excluded if they were under 40 years of age. I forgot to mention that I meant to mention this, it wasn't on the slides, is that this entire protocol was pre-specified and it was registered on the real-world evidence registry that was promoted by ISPI, ISPOR, Duke Margolis a couple of years ago. So it's all on there if you want to take a look at it. These are just some highlights of the methods. Okay, moving back to the slides, the primary outcome here is first moderate or severe COPD exacerbation. And moderate COPD exacerbation was defined by having a prednisone dispensation of at least 5 to 14 days. Severe COPD exacerbation was defined by hospitalization for COPD with the diagnoses in the primary position. For the safety outcome, it was pneumonia hospitalization with the diagnosis code anywhere in any position on that hospitalization. In terms of analysis, this was analyzed using a Cox proportional hazard regression model, looking at the incidence of first moderate or severe COPD exacerbation or first pneumonia hospitalization within 365 days after initiation of Wixela or Advair. There was a grace period because we censored upon discontinuation or switching, and the grace period to allow gaps in between recurrent dispensations plus was about 60 days. Was 60 days in the primary analysis, and for adjustment of confounding, it was 1-to-1 propensity score matching with a sensitivity analysis that added high dimensional propensity score matching. So this is a summary of a few characteristics that were measured at baseline. There were a whole long list of other covariates, but basically what we saw was that in the full cohort, even before doing propensity score matching, they were pretty well balanced. In the generic, there was 18,000 new initiators identified and 27,000 initiators of the brand name product. The age was pretty close even before matching, 70.8 versus 72.7 years of age. But one thing that was different was the proportion that were initiating during COVID-19 versus before COVID-19. And this is due to when Wixela was approved. The uptake was occurring primarily during the pandemic era. So this was also adjusted for in the propensity score, but in the full cohort or in the crude cohort, you could see that there was imbalance there. But in terms of other characteristics that may determine how a physician would prescribe ICS/LABAs, things like having short-acting beta-agonist fills or antibiotic fills for COPD, this is already well balanced even before propensity score matching. Also note at the bottom here, a very small proportion of these patients had their medications prescribed by a pulmonologist. There was about 4% or less. In terms of other characteristics, these patients were on other COPD therapies, including LAMA, which was already pretty well balanced before propensity score matching, but even more closely afterwards. Similarly, they had a similar distribution of eosinophil counts as well as the combined comorbidity index. So these are the results for the variety of outcomes. At the top is the primary outcome, and then the components, as in the safety outcome is at the bottom. So what we see here is that basically we have null results for every single outcome for moderate or severe COPD exacerbation, moderate by itself, severe by itself, as well as for the safety outcome of pneumonia hospitalization. The point estimates are very close to 1, and the confidence intervals are very tight around 1. So there were some pre-specified sensitivity analyses that were in the protocol that was pre-registered on the real-world evidence registry. And so things that were varied are the grace period that was allowed for the gaps in between dispensations of the Wixela or Advair, varied from 60 days to 30 days to 90 days, did an intention to treat analysis, started follow-up later, then also changing the outcome definition to not just require the dispensation for prednisone, but also having a visit. Also potentially requiring prednisone and an antibiotic to define a moderate exacerbation, changing the exacerbation code to have to be in any position for the severe outcome, and then also applying inverse probability of censoring rates for the on-treatment follow-up. And we did this both for the propensity score matched with the predefined covariates, as well as for the high dimensional propensity score matched results. And you can see that pretty much everything continues to fall on the null line with confidence intervals very tightly around null. There were also some predefined subgroup analyses, and this is all for the primary outcome of moderate or severe exacerbation, looking at people with and without baseline COPD exacerbations, those who had severe COPD exacerbations at baseline or didn't, whether they also had asthma codes in their record, as well as stratified by whether they initiated before or after the pandemic began, whether there was baseline spirometry performed, and whether the index prescription was from a pulmonologist. And across all of these subgroups, it continued to have very null results. So basically, general conclusion from this analysis is that the generic fluticasone salmeterol isn't associated with increased rates of first moderate or severe COPD exacerbation or first pneumonia hospitalization. So it performs very similarly, both in terms of effectiveness as well as safety. Residual confounding is always a potential concern, but in this case, sometimes they don't even know that they're getting a brand versus generic depending on substitutions in the pharmacy. So that's a little bit of a natural experiment there. And then there's also the potential for other things that aren't measured in claims like spirometry, or poorly captured in claims like spirometry, diffusion capacity, and imaging data that could potentially be important, but perhaps not in this particular clinical scenario. So those are the acknowledgements, and I was very quick, so I think Will would have taken a little bit more time to explain some of the background clinical context, but I'll do my best to address questions if you have any.
That's a great presentation. Anybody has questions?
Hello. I don't know if you can answer, but any idea of how much of measurement error you had in the particularly in the exposure assessment? I'm very familiar with the data source, and I know a lot of the exposure or these drugs come on the ingredient level, and we can't assess the brand. So did you assess how much of the exposures to fluticasone you have in the data you didn't include because you don't have the data if they were the brand of the generic? And do you have any idea if that could be a differentiation or not?
I believe it was based off of the NDC codes, where you could differentiate which type of drug it was, or whether it was brand or generic, rather than the ingredient level. I'm sorry, I can't hear you.
I wonder if you look at how much.
The microphone, please. Thank you.
I'm just wondering if you looked at how much exposure to the drug you have that didn't have the NDC code that can differentiate, and so how much you miss of people who had the drug but you didn't include in the study because you don't have the NDC code.
No, I didn't assess people who were not included because the codes weren't classified there.
Quick question about sensitivity analysis. Since Wixela was approved in 2019, I saw that there was a pre and post COVID sensitivity, but specifically the post COVID, post 2019 period, how much brand Advair were you actually capturing, or, compared to the Wixela sample size wise?
I do not recall the distribution of, it was declining over time as the market share was increasing for the generic version. So I can't say specifically how much of it was still being captured, but it wasn't like a direct shift. Suddenly everyone was going on into the generic version as soon as it became available.
So I guess my question is, was there sensitivity analysis for that to make sure that you still had balance in that period when the Wixela kind of came on the market, if that makes sense?
You mean finer stratification by time? Like, yeah, we didn't do, it's something we could explore more, but I don't recall doing a very small strata of time in which we were balancing on Wixela versus Advair.
Great. Anybody else? We may have time for one last question.
Since you mentioned it was specified, were there any power calculations to this trial?
Were there any what?
Oh, not trial, study. Were there any power calculations?
No, there was no power calculations.
Okay, so in terms of that and limitations, of course, you could consider with these results that you couldn't see any clinically meaningful difference, but then you didn't know when you started this study whether or not you would be able to discern a clinically meaningful difference.
I guess there were no formal power calculations, but there was a general knowledge of rate of exacerbations in this type of population, and that we had a sample size of potentially 20,000 patients. So
yeah, but I'm clearly on the side of the results are very clear, but it was just interesting to know.
Yeah, in other work that we've done, like for example, for RCT duplicate, we both pre-specified the protocol as well as did formal power calculations before deciding to proceed. But for this particular study, we did not.
Great. Thank you, Shirley. Great discussion. Our next speaker is going to be Dr. Chintan Dave from the Center for Pharmacoepidemiology and Treatment Science at Rutgers.
Hello, everyone. My name is Chintan. I'm presenting on the behalf of one of my trainees. This is his master's thesis. It's looking at the cardiovascular effectiveness of SGLT2 inhibitors compared to DPP4 inhibitors and GLP-1 RAs in patients with HFrEF and HFpEF. In terms of disclosures, this grant was funded by NHLBI. In terms of my own disclosures, I'm PI for a grant from NHLBI, JDRF, and I have some funding from the VA as well. I don't have any conflicts of interest to report, and neither do the co-authors. So we know that type 2 diabetes and heart failure occur very commonly together. 50% of patients who have heart failure also have type 2 diabetes. And about 25% of patients who have heart failure, 25% of patients who have type 2 diabetes also have heart failure. SGLT2 inhibitors are a blockbuster drug that came out about 10 years ago. And initially in the cardiovascular outcome trials, I'm trying to see if I can just make, okay, that's a little bit better. In the cardiovascular outcome trials that were conducted, initially in patients with type 2 diabetes, they were shown to reduce the incidence of heart failure hospitalizations, HHF, and MI or stroke by quite a substantial amount. And this led to dedicated heart failure trials in patients first with heart failure with reduced ejection fraction or HFrEF, and then with patients in the HFpEF. In these trials, we saw that these agents reduced heart failure hospitalizations by about 30%, but these trials did not assess any ASCVD endpoints or MI or stroke hospitalizations. GLP-1 RAs are also a second-line anti-diabetes medications that are shown to reduce MI or stroke by about 15% and HHF by about 9%. Although it's a little bit more controversial with these agents because there is some heterogeneity within the individual drugs within the class. So there's some consensus recommendations preferencing SGLT2 inhibitors for patients with heart failure and type 2 diabetes, and GLP-1 RAs for patients with ASCVD, pre-existing ASCVD. So no study has really looked at the comparative effectiveness of SGLT2 inhibitors versus DPP4 and GLP-1 RAs in patients with HFrEF and HFpEF. So our objective of the study was just to do that in Medicare data and just fill that gap in knowledge. So we used a 50% random sample of Medicare fee-for-service data with Part D from 2013 to 2019. The data elements of interest are, well, let's see if this works, actually. Cool. So the data elements of interest are just your claims databases. So we had sociodemographic information. We had information on pharmacy and medical eligibility on a monthly basis, inpatient and outpatient medical services, and outpatient medication use as well. The study design and eligibility criteria, fairly straightforward. We created 4 active comparison cohorts. We basically required them to be new users for the study medications, using a 365-day washout period where we also looked at inclusion-exclusion criteria at that time as well. Basically, we had two cohorts, pairized comparison cohorts in patients with HFrEF, and then 2 analogous cohorts in patients with HFpEF. In the HFrEF, we had cohort 1A, 1B. 1A was SGLT2 inhibitors versus DPP4 inhibitors, and 1B was just SGLT2 inhibitors versus GLP-1 RAs. And we had that analogous cohorts for patients with HFpEF, basically. In terms of the inclusion-exclusion criteria, new users over 65 years of age, requirement for type 2 diabetes, they could not have evidence of ESKD or type 1 diabetes or any other types of diabetes. We excluded patients who had HIV or cancer. And in terms of just sort of assessing patients like with HFrEF and HFpEF, since we don't have EF or ejection fraction in claims data, we used a validated approach, which sort of just looked at the hospitalizations and just looked at the first or second position. And if they had codes corresponding to HFrEF or HFpEF, we just designated them as in that cohort. Basically, with this definition, the positive predictive values for HFrEF range from 72% to 90% and about 92% for HFpEF. In terms of follow-up, we started following patients up the day after they started the medication, and we ended the follow-up when they lost their eligibility or discontinued their medication, switched medications, end of study period or the outcome. In terms of the outcome, we had 2 primary outcomes, which I realize is an oxymoron, but bear with me. The positive predictive value for those outcomes are about 90%, and it was heart failure hospitalizations and MI or stroke hospitalizations. We only adjusted for 40 covariates. Typically, we do a lot more, but we just had a smaller sample size, so we just tried our best to preserve power and make sure we just selected the main covariates of interest. So we adjusted for patient demographics and select CVD conditions and select diabetes and diabetes severity and things like that. We used inverse probability of treatment weighting again to sort of preserve more power versus PS matching, where we might lose some patients. And it was a propensity score based IPTW, and we also used stabilized weights. I'll briefly go over this, but we also had several secondary outcomes, including composite cardiovascular endpoint of MI and stroke hospitalizations and all-cause mortality. We looked at the individual components of the primary outcomes as well. We did some sensitivity analysis around, per protocol versus ITT. We also had more sensitive definitions for HFrEF and HFpEF because initially we're just looking at patients who were hospitalized, but we also wanted to see, so that's a very high PPV sort of, definition, but doesn't have a high sensitivity. So we sort of expanded that definition to include patients who had corresponding codes for HFrEF and HFpEF, and even in the, in the outpatient setting as well. We also stratified analysis by ICD-9, ICD-10 coding schema just to see if there was any differences with that. Here are the baseline character. Sorry, I have to figure out how to do this properly. Here are the baseline characteristics after IPT weighting. We just downweighted the DPP4 group and the GLP-1 group just to resemble the SGLT2 group, so it's just easier to read. Basically, we had about 2,500 patients in the HFrEF cohort with SGLT2 inhibitors and about 3,200 patients in the HFpEF cohort. This is the HFrEF cohort. So we had about 2,500 SGLT2 versus DPP4 and 3,200 SGLT2 versus GLP-1 RAs in the HFrEF cohort. Basically, after weighting, a lot of those, the standardized differences are still sub 10%. And typically with SGLT2 versus DPP4 comparison, we do see that typically these patients are going to have more cardiovascular disease burden. And compared to the SGLT2 versus GLP-1 RA cohort, where you're going to see a more intense sort of diabetes severity. The cohort was also 60% male, which is within our, which is what we would expect to see. For the HFpEF cohort, slightly different. The cohort is now 60% female, but everything else is still very, very similar in the sense that, the DPP4 group still has a higher CVD burden. And the GLP-1 group is more severe diabetes. In terms of the primary analysis, this is a slightly busy slide, but basically the HFrEF is up at the top and HFpEF at the bottom. The results are very similar between HFrEF and HFpEF, so I'll just sort of discuss them together. So with the SGLT2 versus DPP4 cohort, basically comparison, we see that the SGLT2 inhibitors basically reduce the incidence of HHF or heart failure hospitalizations by about 50 to 55%, and they reduce the risk of MI or stroke by about 25%. And that's consistent between the HFrEF and the HFpEF cohort. In the SGLT2 versus GLP-1 RAs, and remember GLP-1 RAs have some cardiovascular benefit, although there is some controversy with that. They do reduce the incidence of heart failure hospitalizations, but about 23%, but they don't reduce the incidence of MI or stroke, which is again expected because GLP-1 RA also have a very strong evidence for their use against for the benefits on the ASCVD endpoints. Secondary and sensitivity analysis, I have slides for this, but I'm just going to skip it, and we'll just say that they were consistent with the primary analysis. And if anyone has any questions, I can take on we can bring on the supplement slides and go over those data as well. So we concluded by saying that in this population-based cohort study of patients with type 2 diabetes and heart failure, SGLT2 versus DPP4 reduced the incidences, both HHF and MACE, by about 50 and 35% respectively, while when making a comparison between SGLT2 inhibitors and GLP-1 RAs, the primary reduction was in the HHF space, looking at about 16 to 23% reduction in risk of HHF, but very similar MACE risk or MI or stroke risk, basically. The magnitude, what was interesting to us was the magnitude of CVD reduction was comparable in the HFrEF and HFpEF cohorts. And I think if you know HFpEF, there's not many things that work for HFpEF. So this was really interesting and important finding in that regard. Although there is clinical trial data also corresponding to this finding as well. The magnitude of reduction was qualitatively similar to the cardiovascular outcome trials, but more pronounced in effect because we had an older patient population that was enriched by basically looking at, patients who were hospitalized in the past year anyway. So potentially that could explain why some of those findings were more pronounced than what we see in the clinical trials. We also concluded by saying that, there was also the bigger magnitude effect in terms of CVD events in terms of when you make the comparison against DPP-4 and less so with GLP-1 RAs, which is also a very expected finding. So in terms of limitations, of course, there's a potential for residual
Sorry,
confound.
we may have to wrap up.
Oh, sorry.
We're running
Okay.
out of time.
Okay.
Thank you very
So in terms of visual confounding, we don't have access to hemoglobin A1C and BMI. So findings are generalizable to the Medicare population. So we may not know if this is going to have similar effects in a younger population. We were not powered enough to detect differences within the individual SGLT2 inhibitors, and we're not able to study patients with heart failure who did not have type 2 diabetes as well, because it's a very, very small population in Medicare at this point, although we do have that data where it's like bigger in the younger populations and the commercial claims, especially, we do have a bigger slice of data there. So in conclusion, we said SGLT2 inhibitors versus DPP4 reduce HHF and ASCVD endpoints, and then SGLT2 versus GLP, just HHF endpoints. And these findings have important implications and some limitations as well on the prevention of cardiovascular morbidity and mortality among patients with type 2 diabetes and heart failure. And I want to acknowledge that this is a study primarily done by Jimmy. So as primarily as a way to deflect any criticism you may have. And I'm happy to take any questions as well. Thank you.
Thank you very much. Do we have any questions from the floor, please?
Hello, I had a good presentation, and I'm from Taiwan. And I have a question that did you consider renal functions on the study, because like renal and cardiovascular disease, they are high related?
Yeah, that's a really good point. I don't recall if we adjusted for CKD ICD codes or anything. Obviously, we don't have EGFR or anything like that in here. And especially with DPP4, there's really good data to use certain agents like linagliptin at EGFR levels of even 15 and things like that. So that's a really good point in the sense that, they may be differentially prescribed to patients. DPP4 inhibitors may be more preferentially prescribed to those patients. So that's a really good point. I think the definitions for CKD are not very sensitive in claims data. So even if we try to adjust for it, I don't think we would do a fantastic job with that. But I do think that is something we need to, I probably need to go back and see if we did adjust for that or not. Thank you for that point.
So any more questions from the floor, please?
So if there's none from the audience, just one from me. So I know your outcome was related heart failure. I'm curious, in the eligibility criteria, did you also consider excluding any patients that had previous heart failure or any related conditions? The reason I ask is because, however, accurately we try to adjust for that in the analysis, some of these codes can be like very closely correlated with each other, especially in the heart disease area. So I'm curious how you dealt with that.
Yeah, so I think I have a two-part answer to that question, and that's a great question. I think we were primarily interested in looking at patients who had pre-existing HFrEF and HFpEF to begin with, because that's where the data was missing, especially for active comparators and MI or stroke endpoints for SGLT2 inhibitors. So we did not exclude them, because then that would defeat the purpose of the study. But we did look at sort of like, if it was a continuing episode of prior heart failure, which I don't show here, but we did do some sensitivity analysis excluding patients who had heart failure hospitalization in the past 30 days prior to the index date, just to exclude some episode that may still be ongoing, and it just may be readmission of that heart failure that occurred recently versus, a new incident heart failure. So we did look into that. And
Great, thank you.
Great, thank you so much.
So shall we welcome our last speaker for this section, Cheryl Tan from University of Oxford.
Good afternoon. Thank you very much for staying for this session. My name is Cheryl. I'm a pharmacoepidemiologist at the University of Oxford, and I'm delighted today to be given the opportunity to present on behalf of my co-authors on our study entitled Assessing Comparability of Osteoporosis Treatment Groups using real-world healthcare data from the UK and Denmark. And how we did this was by evaluating propensity score and negative control outcome methods to address confounding by indication. This research was funded by Amgen, and I don't have any personal conflicts of interest to declare, but the co-authors have some conflicts of interest disclosures here. So the motivation for this study is that we are all aware that propensity score methods are commonly used to adjust for measured confounding in observational studies. However, some important confounders, such as bone mineral density in the field of osteoporosis, may be missing in real-world data. And to overcome this limitation, we use negative control outcome methods that have been developed to detect unmeasured confounding. And negative control outcomes are outcomes that are not known to be causally associated with the treatment, ideally also sharing the same confounding structure of the treatment and the outcome. And some of these examples of these outcomes could be like ingrown toenail or having an injury to the eye that doesn't have any relation with having an osteoporosis medication. So the objectives of our study was to assess the comparability of denosumab versus oral bisphosphonates, and denosumab is a subcutaneous injection given for osteoporosis. We did this using propensity score methods and also applying different rules for residual bias in NCO analysis. So this is our study design schema. How we selected patients was in CPRD, a primary care database in the UK, having a prescription of either DMAP or oral BPs between 2011 and 2018, and the Danish National Registries, which is secondary care data in Denmark between 2011 and 2017. And we did an active comparator new user cohort design where the DMAP cohort and the oral bisphosphonate cohorts, they did not have any prior use of DMAP or oral VPs in the prior year. And we also excluded patients who were aged less than 50 years with less than 365 days of observation time before index date, who were male, so we only included female patients, and who we also excluded patients if they had a recording of cancer and Paget's disease of bone, because we want to eliminate any other indication for these medications other than for osteoporosis, and also for end-stage renal disease, because this is contraindicated in oral bisphosphonate users. For the baseline covariate assessment window, we assessed comorbidities in the 5 years prior to index date and medication use in the 1 year before index date. And we followed up patients for a maximum of 3 years or until a censoring event, which is either treatment switching or discontinuation, the occurrence of the NCO of interest, or the end of the enrollment or study period. So we use 3 different PS methods to assess covariate imbalance, and this is weighting, matching, and stratification. And how we indicated imbalance is if the ASMD is more than 0.1. As for the negative control outcome methods to assess residual confounding, what we did firstly was to select the negative control outcomes of interest. So this was one of them was early fracture in the first 3 months of the initiation, because in the randomized clinical trials, it's shown that there is no effects of the osteoporosis medication on fracture risk in the first 3 months. And this is hypothesized to share the same confounding structure as the main outcome of fracture. And we also did a literature review for relevant studies that to see what other negative control outcomes were being used. And lastly, we also used an automated algorithm that was developed by Erica Voss. And briefly, this is by searching through the literature and also product inserts to find that there is no association between the treatment and the negative control outcome. And after selecting these NCOs, we reviewed these NCOs with two clinical epidemiologists, and also by double checking that these NCOs that were selected were not listed as adverse events in the product prescribing information. So in total, we consider 110 NCOs for our study. And for the statistical analysis, we pre-specified that we will only study the NCOs with at least 100 events in the whole cohort during follow-up. And we also use Cox model to estimate the hazard ratio. And this Cox model was further adjusted for any imbalanced covariates. And we assessed two different approaches to identify residual confounding. The first approach is if there were more than 5% of the NCOs assessed with more than 100 events during follow-up, with having a 95% confidence interval excluding one. And the second approach is by if there were more than 5% of NCOs with an upper CI of less than 0.75 or lower confidence interval of more than 1.3. And these thresholds were derived from some clinical trial data where they assessed between denosumab and lendronate. There was a 30% reduced risk of fracture in denosumab. So for the baseline patient characteristics prior to propensity score method, in CPRD, we have a total of 200,000 patients. There are 6,500 denosumab patients and about 194,000 oral bisphosphonate patients. And as for the Danish data, there's a total of about 80,000 patients with 4,200 DMAP patients and 75,000 oral bisphosphonate patients. So in general, the patients, see like this can look. DMAP are older than the oral bisphosphonate patients, and similarly, that's what we see in the Danish data as well. We have a total of nearly a median follow-up time of 1 year in CPRD and about double the time in Danish registries. And in CPRD, we could also see that they had a higher risk of previous fracture in denosumab patients compared to oral bisphosphonate. And this was also seen in the Danish registry, although the difference was not as big as the CPRD data. And the last two rows here, number of days since last fracture and the cumulative bisphosphonate use reflects the clinical practice that oral bisphosphonates are usually used as a first line in these two countries. So in total for CPRD, we considered 87 different covariates and 83 covariates in the Danish registries. And prior to the propensity score estimation, about 25% was imbalanced in CPRD and 21% in Danish registries. As for the different propensity score methods after PS matching, we find that 3 to 4% remain imbalanced. For stratification, 3% in CPRD and about 11% in DNR. And for the inverse probability of treatment weighting, about 12% in CPRD and 2% in Danish registries. And the figure on the right is just a visual representation of IPDW in CPRD, where the horizontal and the vertical red lines are where ASMD is more than is 0.1. And so you can see on the x-axis, the ASMD is before weighting and ASMD after weighting. So after weighting, you could see a smaller proportion of imbalanced covariates. So this table shows negative control outcomes, and we see a total of 47 outcomes being assessed in CPRD and 26 in DNR for the stratification and weighting methods, but a lower number for matching. And the ones highlighted in red shows that evidence of residual confounding. So only in approach 2 for the weighting methods that we see no residual confounding based on our pre-specified thresholds. And this is just a visual representation of the number of negative control outcomes that were assessed, CPRD on the left and Danish registries on the right. So the ones that's highlighted in orange with evidence of residual confounding based on the second approach. Currently, there is no consensus regarding the optimal threshold to identify residual confounding. And there is a paper by Marta and Shumi who recommended that if you want to use to calibrate your treatment effects, you should have at least 30 NCOs. And for our study, we used a combination of methods, early fracture, as well as semi-automated selection of large set of NCOs to allow us to have the option of calibrating the treatment effects. So in conclusion, the achievement of covariate balance and determination of residual bias were dependent upon several factors, including the study population, the propensity score method, the prevalence of NCO in the study, and also the thresholds. And future studies should consider a variety of propensity score methods and also account for the stringency of residual bias assessments to determine whether the treatment groups are comparable. Thank you for your attention, and I welcome any questions.
Any questions from the room?
Yeah, could you go back to slide 10, please? So is there the cumulative oral BPUs? If I understood correctly, is it a treatment naive design? So how could there be a non-zero use?
Yes, sorry, I didn't clarify. In the interest of time, I didn't expand, but the cumulative oral bisphosphonate use was assessed 5 years prior to index date. So for our new user design, we only specified that they were not treated in the year before index date. So there could be the 4 years prior to that where they could have used bisphosphonates in the past.
All right, thank you.
Any other questions in the room? I'm curious, you use the CPRD as well as the Danish registry. Any lessons learned from the use of both? I mean, given the differences or similarities, anything that registered with you as you were doing the study?
Yeah, I think there are definitely differences. I think in terms of maybe some of this is definitely a very reduced set of baseline covariates that we show here. But I think in the end, the results, I mean, I guess based on the different methods, you can see different methods, maybe they do a bit better in one database versus the other. So it's good to consider like which method suits which database better. But in the end, this was the first step for us to do comparability assessment. And then the next step we actually did, that is not presented here, we did the treatment effect estimation as well. And we saw similar results between both databases, even though the study population and some covariates may be more heterogeneous between the databases.
Okay, thank you. All right, with that, we will conclude this session. Thank you very much, everybody. Thanks, a huge thanks to our speakers for sharing the interesting research. And on behalf of Kenneth and myself, thanks everybody again. Have a nice rest of the day.
Thank you very much.